Please just make sure that you are on mute. And just so you know, this meeting is being recorded just for members to be able to watch later. Okay, Angie, do you want to go ahead and get the slide started?
Would you like the slides or the poll?
A poll, yes. Okay. I didn't realize we couldn't do both at the same time. So I'm Farheen Qureshi. I'm one of the board members of DFA. So we're just going to get started by getting to know each other a little bit. We want it to be, an interactive session and kind of get to know where people are from, what brought them to this session. So please participate in that poll if you're able, where you're from, if you've joined a Doctors for America event before, where you are in your medical career, and all of that. So, all right, let's take a look. Oh, we have quite a few people from the Northeast, which is where I am right now, although I'm from the Midwest originally. We've gotten some people who are first timers at a DFA event, so that's great. Thank you for joining us. Welcome. And people from all areas and all aspects of healthcare, so that's great. This is definitely a very multidisciplinary topic, so I appreciate everybody's input as we go along in this session. During the session, if we have any questions from the audience, which we very much welcome, again, we want this to be interactive, we want to have a discussion, please do use the chat function so we can interact. Okay. All right. And again, please do make sure that you are muted. Okay. Angie, shall we go ahead and get started with our slides? There we go. Excellent. Okay, again, my name is Farheen Qureshi. I'm one of the board members of DFA. I'm also a trauma surgeon in Baltimore, Maryland. And we do have two wonderful DFA members and leaders with us here today, who I'll talk about in just a second, but Tracy Evans and Lisa Chowdhury. Next slide, please. Next slide. Okay, so before we get started, if you go back one slide, this is Doctors for America is a national organization. We welcome people who are healthcare allies, physicians, other healthcare providers. So please, if you're interested, consider joining, or if you have more questions after the session, I'm happy to talk with you about that. But we appreciate everyone's support and hope you are interested in joining. I put a link in the chat. So next slide, please. So our speakers, as I mentioned, my name is Dr. Qureshi. I'm a trauma surgeon in Baltimore, Maryland. I have also trained, as I mentioned, in the Midwest and in other hospitals here on the East Coast. So I'll be talking about those experiences a little bit later. And I just want to also talk about our other great speakers that we have joining us today, who are other leaders within DFA. So Tracy Evans is a hospital director of the Violence Intervention Program in Paterson, New Jersey. She is on DFA's National Steering Committee for Gun Violence Prevention. Her professional career has included emergency clinical care as a community paramedic, as a flight nurse, and as a nurse practitioner. Lisa Chowdhury is a critical criminologist and currently an assistant professor in the social science department at Borough of Manhattan Community College. She is co-founder of the nonprofit Reimagining Justice Incorporated. Dr. Chowdhury is the program director of the hospital-based violence intervention program at St. Joseph's Hospital in Paterson, New Jersey, which is the first HVIP in Paterson, and has thus far engaged over 90 victims of violence. So I really look forward to what Dr. Evans and Dr. Chowdhury have to speak to us about today. Dr. Evans, would you like to get started first? Oh, I apologize. Actually, I will get us started. So from a physician standpoint, I'll just do a quick intro. Next slide, please. Just to give you a little overview of HVIPs, some of you may be familiar. For those who are not, my own experience has been probably quite different from Dr. Evans and Dr. Chowdhury, but it's been from the clinical standpoint. Please remember to mute yourself, everybody. Okay, here we go. So I have here we go. Muted myself. So I have interacted with HVIPs and mainly as a clinical provider. Currently, I work with a program at my hospital called the Center for Hope, which interacts primarily with children who have been victims of violence, unfortunately. But we also do have programs that work with adults and specifically with women faced with interpersonal violence. Baltimore has a very large community program that works on interrupting violence called Safe Streets. For anybody who's in the Northeast or in the Baltimore area may be familiar with that. I also trained in Washington, D.C., which has a violence intervention program at their hospital, at MedStar Washington Hospital Center, which is also a very large level 1 trauma program. And I can tell you from experience that these hospital responders at my current facility and at the others are able to offer services to these patients that, as clinical providers, we may just not be familiar with or not have the resources available. And when we're able to work in concert with hospital responders and with hospital-based violence intervention programs, I think it really gives a far more holistic healing process to our patients because, I can stitch people up, but ultimately what we want to do is prevent them from coming in the first place. As anybody else who's a healthcare provider here knows, prevention is much better than treatment if we can do that. Next slide, please. So again, just light overview for anybody who may not be familiar, though many of you on this video chat probably are. An HVIP, and this is based on the practice management guidelines from the Eastern Association for the Surgery of Trauma, is a collaborative program. It works between healthcare providers and community partners, engaging patients who have been afflicted by a violent injury. And the idea is to engage them right in the hospital during their index admission. It prevents a delay in initiating trauma-informed care and in violence interruption because oftentimes these patients may be in the hospital, either it's just an ED visit or an overnight visit, but sometimes it extends literally weeks or months, depending on the severity of the injury. So this really takes advantage of a unique opportunity available when the patient is in the hospital. Initially, these were piloted by very large trauma centers, such as UCSF and University of Pennsylvania, but it has really expanded throughout the country, including even in the Midwest where I trained. Next slide, please. So according to EAST, an HVIP addresses the psychosocial challenges that patients afflicted by violent injury may face and really transforms medical treatment into a catalyst for life and societal change. And our other speakers will talk in more detail about that. HVIPs can differ in the different services that are offered at the facilities I worked at. Each one had different resources available and offered different resources to the patients. But I think each one uniquely offered something very special to the patients that was necessary. And they really, as I mentioned, try to utilize that sole access point, quote unquote, either the ER or hospital admission as an opportunity to enact change. Next slide. Just some overall statistics on why this is important. Trauma recidivism, which I think Dr. Evans is going to speak about more, is estimated anywhere between 10 and 50%, depends on the studies that you look at. Most of the estimates are closer to between 40 and 50%. As far as patients who are at risk of re-injury within 5 years. 20% of those patients who do suffer a re-injury within 5 years will be at risk for homicide, as opposed to a non-fatal injury. Urban adolescents treated after GSW in one study were more likely to die of a repeat injury than any other illness or condition for which they presented to the facility, the index facility hospital. Injuries are physical, and that's primarily, what I see initially in the trauma bay, but injury is all encompassing. It's emotional, it's psychosocial, it's financial. And so really holistic multidisciplinary care is necessary. From the standpoint of finances, fatal and non-fatal firearm injuries cost tens of billions of dollars in healthcare. Injuries as a whole do, but especially violent injuries. And hundreds of billions of dollars when you also account for socioeconomic costs, which was done in one study, and addressed that over $170 billion were lost from the United States. If you are also looking at the social costs and the economic costs of firearm injuries. So again, trauma hospital presentation, it's just a unique opportunity and an important one that I'm glad that we're going to learn more about today. Next slide. As far as research, there are some good practice management guidelines out there. However, they specify as well that really further research in this area could be so helpful. Right now, there are very small sample sizes in the studies that are done. Many of them are either opinion articles, or they weren't able to have a control group, or they have small sample sizes. So there are limitations to the current research that we have. So if that is an interest of yours, as well as hospital violence intervention programs, I think that would be very helpful moving forward, especially in providing support, empirical evidence, funding for these types of programs, and to establish best practices moving forward. Next slide. And those are just some of my works cited, which I'd be happy to pass on if anybody's interested. Next slide. Okay, Dr. Evans, would you like to proceed?
Can you folks hear me? Our hospital internet service is unstable at the moment.
Yes, I can hear you.
Okay, so I've got my camera off. I appear as a disembodied voice. I apologize for that. But my role here as the hospital director of our violence intervention program is one of oversight and advocacy. I know many of the physicians on the call have a variety of specialties. And so I wanted to frame this issue as a trauma center issue, simply because survivors of gun violence typically are transported to trauma centers either early on in their care or as a tertiary care transfer. But the reality is it does not require a trauma surgeon or emergency physician to advocate for programs like this. It's very important when we work with a community partner that we have a bilateral arrangement, and it allows the hospital to really meet its mission and vision, which is not only important to certainly the patients and their families that we care for, but also in meeting the needs of our community and getting people to care that they that they need to have and should have. The hospitals are all required to complete an IRS community health needs assessment. It's a 501(r)(3) form that requires hospitals receiving federal funding and for tax exempt status to do a triennial evaluation of the community and the needs for that specific community. That can be fraught with problems for the hospital, especially in a mixed urban suburban type environment where sometimes the needs of the communities most disproportionately effective might not rise to the level of senior leadership. So that's something to be aware of. It's also really important that the hospital be available on a full-time basis. They're needed in many cases because the smaller community organizations simply don't have the financial leverage. We're working under a large-scale federal grant right now, which is a reimbursement-based grant. It's very difficult for a community partner to access that amount of funding. Also, hospitals have quite a variety of mix in their labor expertise, physicians, social workers, nursing, as well as the business business support teams and senior leadership, as well as sometimes a robust foundation for philanthropy and grant writing support that a smaller community-based organization might not have. Next slide. So what we have found in our initial goals for the program, we looked at, number one, providing long-term case management for this particular population of typically youth, many times from the Black and Brown community, typically socioeconomically disadvantaged, underinsured, and extremely fearful for their lives and the lives of their families. So what we found is that if we get these patients and their families plugged into trauma-informed care and long-term case management, that we typically do a better job in providing the overall care that they need. It also is advantageous for the hospital to follow up with these patients because it keeps the patients funneled towards a more comprehensive type care in other areas of their healthcare. So they have access, if they're uninsured, to our numerous clinics, for example, for a variety of different specialties, which actually in the long run meets their overall care needs and gets them plugged into a healthcare system that they might not have availed themselves of for a variety of reasons. And it provides that wraparound service for all intensive care. It also keeps patients from returning to the emergency department for wound checks and bandage changes and pain management if they know there's a supportive plan in place and follow-up appointments are made. It's critical that the hospital liaise with the community groups to do this because the hospital simply doesn't have the expertise or, quite frankly, the credibility in the community to always make sure that these things happen. Next slide. So how does that work? So for the hospital, we found right off the bat that we had a number of cultural issues within our hospital. And I don't mean a race or gender type cultural issue, but in many cases, it's a we versus they. From a personal perspective and from the many caregivers that I've met with, we typically have thought, well, we've built this, 10-story hospital. If they want care, they'll come in. And the reality is it's not always possible. People don't feel safe. There are a number of urban legends in the community. The one most glaring to me when I went out into the community to meet community members was the urban legend that people had been shot or injured in the community and were alive. And when they arrived at the hospital, they later died. And several people expressed concern that we were either allowing them to die or assisting in their deaths to harvest organs. So that is certainly something that we just simply weren't aware of. It's also very difficult for people to recognize that patients who were involved in violence are typically polytraumatized, not only emotionally and physically, but they also come potentially from, community groups, youth groups, justice-involved groups, and we don't want to blame, shame them, or make patients feel that they've deserved what has happened to them, for example. And it simply is a paradigm shift, even from your basic level caregivers in the hospital, such as transport services. Rather than say, who did this to you, our staff need to be coached in, we're here to help. How can we help you? And pivoting that model around. We also have to recognize too, from a care provider standpoint, that whether or not the survivor of the shooting is a perpetrator or simply a happenstance victim, that the injuries sustained by the patient also greatly affect all other members of not only the immediate family, but the community as well. And they become the second victims. And so the hospital, we weren't always so great with that. We also found that we had a number of barriers between our security department, who is led by a former police officer, and community policing, who oftentimes would come in and, quite frankly, violate some of the rights of survivors in an attempt to solve a crime. And that has been an epic journey for our hospital. And of course, finally recognizing that the survivors are in fact survivors. And by shifting that mindset, not only for them and their families, but also for us as caregivers, that they are survivors. And it helps to keep away that victim mentality, which is so pervasive in our overall American culture these days, stacking on levels of victimhood. And that really has begun to take shape in our emergency department. Next slide. And then I'd like to turn this over to Dr. Lisa Chowdhury. And she's my community partner in this program, and she can tell you how it actually works.
Hi, everyone. Thank you so much for having us and tuning in tonight. I love my partner, Tracy, and I see the rest of my HVIP family. I see Dr. Pruden and Steve on, and I appreciate all their partnership with St. Joseph's Hospital, because we really couldn't have launched this program without their guidance and their support. So I'm going to go through the slides. We can go to the next slide. So I'm going to go over some of the our mission statement as far as Reimagining Justice, which is a nonprofit community partner, our program model, some of the preliminary data from our first year of running this program, some vignettes to talk about actual cases we've been supervising, and go over the importance of having healing events in the community to change social norms. And then I'll show you some of the pictures of some of the work that we've been doing in the community. So next slide. You go to the next slide. Right. So our mission as a nonprofit for Reimagining Justice is to really create healing-centered solutions to community-based violence. Gun violence has had a disproportionate harmful impact on young women and men of color. Solutions that have addressed violence have mostly centered around deterrence and reactionary practices that include aggressive policing, gang task forces, and enhanced sentencing. These solutions have led to mass incarceration and the disruption of the economic and holistic growth of Black and Brown communities. Our mission at Reimagining Justice, Inc. has been to highlight the importance of addressing violence by using evidence-based models such as the HVIP, crisis intervention, public health models, theories like transformative justice models. The organization also emphasizes the importance of investing in resources that address the social determinants of violence, such as poverty, housing insecurity, food insecurity, high rates of unemployment, structural racism, and mental health issues. Our agency has advocated on the importance of understanding the long-lasting effects of childhood trauma and structural trauma on communities of color. The overall mission since the incorporation of our organization has been to advocate to reimagine a system that incorporates culturally responsive, evidence-based, and trauma-informed solutions that adequately support communities that are most impacted by violence. Our focus has been to engage stakeholders and community members on understanding the importance of investing in approaches that support community-based public safety solutions so that we can focus on prevention and intervention. Next slide, please. So since we've launched this HVIP, which is one of the models that we've utilized to kind of create these healing center solutions to violence. Just to give you guys a little background about myself, I've been working I worked as a juvenile probation officer for 10 years in the city of Patterson. I grew up in a neighboring town called Passaic, and working during my tenure at probation, I used to see, I used to lose so many young people to gun violence. So it became really important to figure out how do we create evidence-based solutions, because often, even myself, I was a part of a gang task force. And sometimes those deterrence and surveillance models aren't always effective. We might put a Band-Aid on it. We might lock somebody up for a little while, but that doesn't mean that root cause of that violence has been solved. So when this RFP came out to create an HVIP program, it was important for me to partner with St. Joseph's Hospital to see if we can bring this type of programming into our town. So this is actually the model. So what happens is usually St. Joseph's Hospital, when a patient arrives at the trauma bay, we get a call on our hotline, and then we dispatch a team that goes out to the hospital. At that time, the security department asks the patient, do they want to speak to us? They kind of explain our program and provide a brochure. If they say that they do want to enroll or speak to us, then we go on and set them up for intake. And from the intake, we start, supporting them with community-based referrals, whether it's follow-up medical appointments, if they have to fill out a victim crime compensation application, if they need linkages to other resources, we try to make sure that they get those access to those services. Then we also assign them a case manager for up to 90 to 120 days to help them with any of their short-term services. And then if they complete all of their short-term goals, because this program is predominantly client-centered, we actually then make sure that we complete what's called a healing ceremony to kind of congratulate and celebrate their all the things that they've overcome in that time period. And then if they are re-injured, they start the cycle over again. Next slide, please. During their time in our program, we have a case management model. So once the HVIP coordinator does the intake at the bedside, they hold on to the case for about 3 weeks, link them to immediate needs, such as some of our clients are dealing with housing crises. They don't have insurance. They might need SNAP benefits for food insecurity. Some of them don't even have any IDs. So we try to get them linked to those resources right away so that we can move them on to case management. We also have a victim support specialist. One thing that we learned from doing this program that we found was very interesting is that many victims of color are entitled to victim crime compensation, but because there's no knowledge or access to as far as how to fill out the application, the only time they really utilize that fund is for funeral services. So we hired a victim support specialist that hand walks them through that application process. We also created an account in the system so that we can be that liaison between that victim and that and the VCCO office so that we can see the status of their application. Once the intake is done, we create an initial safety plan. So our job is to try to reduce retaliation. And the way we do that is by having those honest conversations with this survivor, right? What are their goals in their life? What will they, and we hired credible messengers. These are people that have transformed their lives, but might have been impacted by violence themselves, whether they were perpetrators of violence or victims of violence. For example, our HVIP coordinator is actually a 2-time gunshot victim, and he survived, overcame that obstacle. He's also justice involved, but he learn how to transform his life and be a leader now. And his knowledge and his engagement at that bedside is key, because that's kind of, what some of our participants want to see. They might have never seen a mentor that can kind of teach them how to navigate this world, because they're dealing with so much trauma, so much confusion. And that bedside moment is pivotal as far as what decision they're going to make next in their life. So once that initial intake is done, we create a safety plan. Some of them can't return back to their neighborhood. They might need to have relocation, and we've done that. We've helped them with that. Some of them might, not even have insurance, or they've never even had a primary care doctor. So we try to link them up with those resources. After that, the case manager links the participant with ongoing resources and helps them reach their goals. Also, we have weekly case conferences with a licensed clinical social worker. We have a crisis interventionist who's been a credible messenger caseworker for years. So he provides his input to help some of our case managers navigate some of the complexities of dealing with this population, because some of our case managers are not credible messengers, but they still care for their clients, and they need to sometimes understand from their lens, right? That, why is it that some of our clients want to react in violence? So those conversations are had with the LCSW and our crisis intervention specialists. After that, we have our operations director that makes sure that all of our data is being entered properly. And then the whole team kind of works together to do community visits. And once we do evaluations after 30, 60, and 90 days, we decide whether or not, this client should be pushed, kind of like celebrated and now have a completion ceremony. And then we ask the client, do you want to continue with case management, or do you feel that you're ready to, kind of take on the world by yourself, right? And just use us as an advocacy partner. And if they want to be extended, they can be extended up to 120 days. Next slide. We also have recently hired an HRI team, which is a high-risk interventionist. This is probably one of the most proudest things that I think that I've been able to do while starting this program. We hired 2 young men who are recent gunshot survivors. One was injured in March, the other one was injured in April. I've mentored them for years, and when I came back and did this work in Patterson, it was heartbreaking to see them at the bedside in the hospital, but they really wanted to be a part of our program once they saw all the healing that we were able to bring them at their bedside, and just from living through that experience. So when they said that they did want to be a part of the truces and trying to do some mediation in their community, we found a way to get them on board with our program. So what they basically do is they're a part of our daily weekend, check-ins, where they look at all the different crises that might be going on in their immediate neighborhood. They're able to stop any rumors that may have gone out of hand, try to do some mediations in their community. They meet with me directly so that we can train staff on how to engage the community members or be more culturally responsive, and how to talk to survivors at the bedside so we can do a better job, because they're more of that peer group. They provide mentorship for students and peers in the community. They're also going to start working on safe passage. What safe passages is to be available during when school dismissal happens, because that's usually when like beef spur with different schools meeting. So they're going to start going to a certain school where there's a lot of conflict going on, so that they could mediate some of those conflicts before they happen. And another example is for them to just be a role model, right? Because they're very highly impacted and influential in their neighborhood. So just them, now promoting this program and talking about their own healing journey can be this credibility, bring this credibility to their peers. Next slide. So some of the data, preliminary data from this year's pilot program, is that we've engaged 103 victims of violence from the hospital since October 2020 to September 29th. 72 victims of violence were directly from the bedside where we got the calls. 31 victims of violence were from the community. So prior to us launching in the hospital, we went out in the community and spoke to communities that were really impacted by violence so that they were aware about our program. So what they would do is if they were injured due to gunshot victimization, they would actually ask for our program in the beginning. So that really helped us when we started going out in the community and educating everyone about their rights as far as survivors in terms of VCCO, victims services, and also the different services we offered. 90 of those victims of violence out of the 103 were gunshot victims, mostly between the ages of 20 to 35 years old, mostly from 2 wards of the town, which is 1st and the 4th ward. And many of the shootings really just happened amongst 6 blocks, which is even more heartbreaking because we knew that some of this violence could be preventable. Since we launched the program, 2 of the gunshot victims that we work with were re-injured, and both were in August. Next slide. So just to give you guys a quick, vignette of a sample case. We had this one young man. He was a gunshot victim from December. His gunshot victimization led him to be permanently disabled. He had housing insecurity. He had no family to really house him. He had no insurance. He needed to, apply for disability, food benefits. The social service system was incapable of dealing with disabled participants. We would call the housing security hotline, and they basically, for the county and the city, and they all said that they had nothing that was handicap accessible for this participant. He had no family that wanted to really get involved, and some of the barriers to him even getting housing was that he was justice involved at one point. So with this case, not only did we have to deal with the fact that he was just injured due to gun violence, we had to now figure out how were we going to get him to physical therapy, how are we going to get him a primary care physician, how are we going to get him his disability benefits, making sure that he consistently has food, because it's not like he could cook. We also had to contract home health aides, because we had to also use our funding to put him in a hotel that was handicap accessible. Even doing research on what hotels are handicap accessible in the neighborhood was hard. We couldn't just put him in a assisted living place because he didn't have insurance right away. We're still working with this case. He doesn't have, he didn't have all the documents he needed from a primary care physician. So this is just an example of how intensive some of this case management and some of the needs are of some of our clients. So this is one case. You can go on to the next slide. Another, another survivor we had, she was also a gunshot victim. When we first met her, she was obviously dealing with the trauma of being a gunshot victim, but she was also dealing with housing insecurity. She had a lot of difficulty getting employment. She was working in HelloFresh, which is a cold environment, which required her to lift and stand up, and her gunshot injury was in her back. So she couldn't stand for a long time, but she still needed to make a living. She didn't qualify for disability. So what we did was we linked her to physical therapy. We were able to get her a SORA license so that she could get a security job. And we were able to help her fill out Section 8 housing. So recently, just last month, she got her first apartment. And she also got linked. We also were able to help her get linked to a school security job. And now she wants to work on her home health aid license to help other people that are injured. This is just an example of what this kind of case management can do for some of our clients, especially when they're dealing with so many different, they're dealing with trust issues, they're dealing with the fact that they've been victimized in such a way. So this supportive, holistic healing is so important in their journey. Next slide. So since we started doing this work, we realized that prevention is key as well. And we wanted to get the whole community involved. So in those areas that were mostly impacted by violence, which were really the first and fourth ward, we began almost like adopting the blocks, right? We would bring, game trucks, we would bring food out, we would bring DJs out. And this was a way to start engaging young people in conversations about violence and mentorship. We had 29 events since we first launched the program since October. Some of those events also included Stop the Bleed training, which our trauma team was so essential with our HVIP team. Tracy, Steve, and Dr. Pruden would come out and teach our community members to be healers themselves so that they knew how to stop the bleed if one of their community members were injured. We had a healing concert over the summer because there was an uptick in violence in May, where we had 28 gunshot victims. And some of those incidents were mass shootings where we had 6 victims at a time, 7 victims at a time. So we were kind of desperate on what can we do. And when we talked to the different communities that were mostly impacted by violence, they kept bringing up music. So we were able to, gauge conversations in the background and quickly put together this healing concert where we had 7 block parties during Wear Orange, which is a national day to enlighten people on the impact of gun violence. So we partnered with Moms Demand Action. St. Joseph's Hospital actually funded the concert. We were also able to get donations from various different community partners, and we were able to engage over 1,000 people in that concert and get every neighborhood. That some of these neighborhoods have been beefing. Some of them were recent victims of violence, but they all came together, about 200 of them, in the center stage, and there was not one incident of violence. Even that whole weekend, despite everybody being out, 7 block parties that were watching the concert as it was going on, there were 0 incidents of violence from Saturday to Sunday. So it was very impactful throughout the neighborhood. As we started doing this, especially in the summertime, we wanted to make sure that we didn't continue to have gunshot incidents throughout the summer. It increased our community engagement as months became warmer. In May, we had 28 gunshot victims. In August, there were 10. In September, it was actually 16. So I just did the data today. And part of that reason is also in August, we were exposed to COVID. So doing this work during a pandemic is especially hard, right? Because we have to be out in the community. We can't really work remotely doing what we do. And in August, we were exposed to COVID twice, which made me shut down the office on 2 occasions, which really led to us not being able to respond to the hospital as much as we wanted to. Next slide. So these were some, as you can see, the violence peaked in May. And then in June and July, it started getting lesser. In August, there were 10 gunshot victims. The data's not right there, but we just ran the numbers today. In August, there were 10 gunshot victims, but in September, it spiked up again at 16. Next slide. These are some of the pictures from our healing event. Next slide. This is our wonderful trauma team from St. Joseph's Hospital that is doing Stop the Bleed in some of the neighborhoods that are most impacted by violence. Next slide. These are some of the game trucks where we go to the neighborhoods that are mostly impacted by violence and try to bring some healing and some good spirits to that neighborhood, and also train on Stop the Bleed and engage them in our survivor services. Next slide. This is, I'm also a yoga instructor. So these young ladies actually reached out to us because last year, about 7 of their friends were shot due to a mass shooting. And they reached out to us for help to help them create a memorial for their the passing of their friends. 4 of them died from that incident. So now they've been coming to us in our organization, and I've been able to, teach them yoga and different coping mechanisms that are that help them with some of their trauma. Next slide. This is one of the neighborhoods that was really impacted by violence. They had several victims of violence in their neighborhood. We were able to take them to go bowling outside of the city of Patterson. And it seems like, is this the solution? But actually it is. When you teach people how to change their social norms and build bonds and relationships, you'd be surprised at how many amazing mountains you can move with that. Next slide. This is the healing concert. As you can see, we're all on stage, just telling the young people in the audience, please, let's stop the violence. Let's make sure that, they can be linked to resources so that they can engage in more pro-social, activities. Next slide. And that's it. Thank you.
All right, thank you, Dr. Evans, Dr. Chaudhry. Now I'd like to move on to the discussion and Q&A portion of our session. I'm sorry, I'll come back here on video. We have some great questions from our audience. If anybody else has questions, please feel free to drop them in the chat there, and I will add them to our discussion. Tabitha Aditi asks, is it possible to put her in touch, or do you know of any HVIPs in Texas? She's working with the coalition on securing funding for these types of programs, which is great. Thank you, Tabitha, and very necessary. She's knows of examples outside of Texas, but not within. I don't know of any off the top of my head, but I'd be happy to reach out to my contacts. Dr. Evans, Dr. Chaudhry, do you have anything to add? Or I think this would also be a good segue for anybody that is wanting to start such a program or get into such a program. What other kinds of resources are out there and available?
So I'll take that to start with. It's almost a full-time job for the community organizations and for the hospital to find funding sources, and certainly a part of a plan when the hospital undertakes something this sizable, and our first round of funding was 1.87 million, is sustainability. Dr. Chaudhry's team is rather sizable, and they should never feel food insecure, and it would be devastating not only to her team members but also for the community if the doors were shuttered on October 1st or at the end of a grant cycle. So the finding the funding needs to start before you even get the first grant, really, and you need to have the resources. And the hospital, actually, because of maternity leave for one of our grant writers, ended up having to outsource to another company to simply keep the lights on while funding pieces could be cobbled together. And so that is really critical. But I just want to say, although I have worked with Lisa now since February of 2020, I am just every day blown away by her passion and her perseverance and her persistence. And I don't want to tell you, she's vertically challenged, but you do not miss her in a room because she lights up the place. And without her, the people of Patterson, who you never hear about on national news with mass shootings, and she's just identified several in our forgotten community that is 5 by 9 miles. We are tiny. Without someone like that in your corner, hospitals and even physicians, we're dead in the water without having that kind of activism. So again, every day it's an honor, Lisa, every day.
Thanks so much, Dr. Evans. We have some other great questions to discuss. Jean, RN Injury Control asks, are there any truths you've observed about young men who've become healers or interrupters in your organization or elsewhere from having been perhaps a gang member or perpetrator? In other words, that transition in identity.
Absolutely. So most of our outreach and frontline staff are what you would call healers who are a part of these organizations, street organizations. And just today I was training two of my HRI staff who are credible messengers who have been involved with the violence and have decided to transform their lives. And I just want to say this takes a lot of courage to do this work. These young people live in these neighborhoods still. So I always have that in the back of my mind. I'm able to go home. The doctors are able to go home. The nurses are able to go home. But their home is where this violence is happening. And it's a lot of mental health and processing that has to be done with them. Just 2 weeks ago, one of our HRI members, he drove his friend to the hospital because another shooting happened. And that young man died, the next day. That's how close some of our staff is to the problem because they're still in it, right? So we have to be very mindful that this work takes a lot of courage, and this young man is only 22 years old. So when we decide to bring them on, there has to be a lot of care and a lot of resources and a lot of support, and also understanding that professional development is a part of it. We might want data and stats and all these kind of things, right? Even today, my lecture to them was like, you have to document, but you also have to have the care and the reality is that they probably can do the job though, because I know since I've hired them in June, shootings have gone down because I know personally that they have helped to have broker some difficult conversations. And just because of their reputation, people have put the gun down or had a ceasefire. So I just want to acknowledge that. So yes, they are healers, but it's going to take, if we're going to be invested in this work, then we can't just expect them to be robots because they're still living in this world, right? They've transformed their lives, but that doesn't mean their cousin has, their friend has, or their family member has. So let's just make sure that we're mindful of that as this becomes more and more encouraged to do in different towns and cities across the country.
Caleb Schultz asks, how can we build evidence that works? This is certainly a feel-good intervention approach, but I'm frankly surprised by the lack of evidence regarding outcomes and effectiveness. Are these universally defined? I will add, I'll be happy to answer this question initially. So yes, it is, for anyone who does research, sometimes it's hard, especially in areas such as this, to get good empirical evidence. For instance, there was one study that was done where the IRB actually refused to allow a control group because they felt that it would not be ethical to deny the opportunity for patients to work with a violence intervention program. And so they had only an intervention group. So, and then also just, there are barriers, to engaging patients. And so sometimes the sample sizes are small. As we mentioned, funding sometimes is difficulty. So there's many barriers here. And also in multiple studies, they found that they weren't able to necessarily follow the patients out through the entirety of the study. So there's been multiple barriers. There are some great evidence-based practice management guidelines with the Eastern Association for the Surgery of Trauma. Their outcomes specifically that they looked at were primarily recidivism, so intentional violent re-injury or death. But they also looked at things like arrest and incarceration, substance abuse, quality of life, mental health issues, re-injury or death, as I mentioned, job and school attainment. So, there are various outcomes that are out there and defined, but they weren't able to really find enough evidence. And I don't know if Dr. Evans or Dr. Chowdhury want to add anything to that.
I have a very strong opinion on this, and me being a sociologist, I think that in doing the work, so I call myself a scholar activist for a reason. Quantifying this work is going to be difficult, right? Because you have a lot of structural barriers, and if you're measuring whether or not this program works based on recidivism or those common measures like job outcomes and all that, then yeah, you're not going to get the data you want, or what do we consider success? So instead, I'm a big advocate for participatory action research, qualitative research. Some of the things that I want to know, even us doing this work as we're approaching our year, is what is it about that gun violence intervention that we did at the hospital change them or change their mindset from retaliating? I want to know that, right? And I know that I could get that answer. The only way I can get that answer is from a focus group, or is from a, it's from a study that's more qualitative. It's not going to be from a quantitative study. So I think that we need to, really rethink our idea of like, when we do, especially when we do research on Black and Brown communities, right? There's also a lack of trust. And also we need to hear the voices of those frontline workers, giving them credit for, and having them be a part of the research as well, right? Instead of us coming in as outsiders getting credit. And I've seen that, and I'm sure Dr. Pruden and Dr. Evans can talk about. We've had big university hospitals that are, R1 hospitals that have tried to come and get our data, and I push back every time because I don't agree with that. I don't want us to be data centric. I want us to be human centric. Well, I know this works. We've seen it. We've seen it every day in the work that we do. But we can't really. We also have to think about, the reality is the conversations we're having are difficult ones, right? Now, how am I supposed to report without being a mandated reporter, right? That somebody might have had a gun and we talked them out of it. That's a hard thing to start studying. You get what I mean? Like, and do I really want my frontline workers to talk about those? There's so many things to think about in this research. And I think the only way to do it is having community participatory action research, qualitative studies to really talk about the kind of the roots of this work.
Yeah, great. Thank you so much. And Dr. Pruden also put some really great things to think about in the chat as well. So some other topics that I just wanted to discuss a little bit with our speakers. We mentioned it a little bit, but if someone is interested in having a hospital-based violence intervention program at their facility, where should they go to identify resources? Dr. Evans, I think you have some great resources that are available.
I do. Well, the first thing I would suggest is assemble your stakeholders and think really big, because the hospital tends, many hospitals, we oftentimes live in ivory towers and silos all at the same time. So you want to certainly get senior leadership buy-in, but you need to involve all different sorts of community groups, funders, different departments within the hospital. You're going to need to be involved with first responders, specifically law enforcement. Everybody at the table is certainly right in their own minds. And so if you can't come to an agreement around a table and then narrow your focus, that's the most important thing. So that's where I would start, is stakeholder identification. And then at the same time, have a sidebar looking for funding. Federal funds are certainly a lot larger when you do ultimately receive the check, but the documentation is just horrifically cumbersome. So we also started by bringing on an accountant here in the hospital to manage the flow of documentation. And then the American College of Surgeons, again, primarily focused on trauma, the Committee on Trauma within that organization, they have guidelines, a step-by-step guideline. I think it has 7 steps, and it outlines what you need to do if you're looking to initiate a hospital violence program. A nice way to begin is on the trauma service, but we originally tried to have it within the trauma service, but the trauma service typically deals with patients upon admission, and with a goal of reducing retaliation. We need the community partners to arrive to the emergency department. We have a truce area in the emergency department. We need to have that started there. It is truly a multi-system initiative, and there is no peg within the hospital system that is any further up the rung and the other. Even the C-suite, they can't make anything happen. And we brought in our community partners, put them through hospital orientation. They signed confidentiality and HIPAA waivers, and they're actually summoned to the bedside with a hotline number called by the emergency physician. They can consent the patient if it's at all possible, depending on the severity of the issue, or can go to the floor and consent the patient the next day. And that allows for seamless communication. The American College of Surgeons had a lot of information on that, as well as I see in the chat the HAVI, H-A-V-I, I think it's Hospital Alliance for Violence Intervention. They tend to be the mediary between the federal funds and the states, which in our case, New Jersey, that's where the funds come through. So it's layer upon layer upon layer of bureaucracy, quite frankly. So you're going to need to put on your HIP waders and your BS detector and, get to work. Because as you heard from Dr. Chowdhury, the hospital can't do this. This is not our bailiwick. And we really need to, we need everybody, all hands on deck.
All right, well, thank you again. Oh, Dr. Chowdhury, do you want to say something?
And from a community partner standpoint, we need the advocacy from the hospital. So when we're doing this work, remember, violence is very political, the word violence. So you have law enforcement that wants to be a part of the conversation, prosecution, the mayor's office, right? So because of that, if we didn't partner with a large institution, just as powerful of an institution like a hospital, nobody would even take us seriously. They would have just seen us as these street outreach workers that, oh, they're trying to do something. Oh, that's nice. That feel good work. But because we were aligned with the hospital, because we also got professional training, because we had some leverage, right? Because we were partnered with this institution. And I also want to say, as an institution that's supporting this type of programming, our hospital didn't take many administrative costs. And I think that they allowed us as the community partner to get most of the grant money. So we were able to funnel that into the community. And to me, that speaks volumes. And in turn, it helps the hospital, right? Because now we as a community partner can leverage the platform that the hospital's in. So I think that it's a two-way street for us as community partners to get resources, right? Because we might not have the infrastructure to be able to hold on to a large federal grant, but we can build that infrastructure with them passing through the money from their organization, and for them to build trust with the community, right? Since we've started working with them, there was gaps in communication that now that we're in the hospital, we were able to alleviate. So I think that it's a two-way street, and if the hospitals are interested in doing that, they need to understand that their role is as an advocate for this community partner.
All right,
Well, close out one last thought. I'm sorry, Dr. Crochet, just one last thought. When you're looking at models and you're considering beginning a program like this, there are typically two models. There's a hospital-based model where the hospital owns everything, hook, line, and sinker. And there's the hospital linked type model where we are linked with the community. That piece is critical and cannot be underscored.
All right, thank you everybody for joining us. I'm just going to be respectful of everyone's time. Thank you again for joining us. We appreciate all of your input, and we had a great discussion. Please connect with DFA on Twitter, on Facebook. Please consider joining as a member. Also, please, there's a link in the chat to a survey. We'd love to hear feedback on what you thought of tonight's event, what you'd like to see in future events. And thank you again, everyone, for joining. Good night.